Recording in progress.
Ankit sir, shall we start?
Yes, we start now. Rafi, is it possible to put everybody on mute? Or
I have made everyone mute, so the co-hosts have to unmute themselves.
yes. So, good evening, good morning, or maybe good afternoon. Namaste, everybody. So, today's webinar is on Rh system and its current challenges in transfusion. As we know, the ATM is organizing some webinar educational programs for ATM members and non-members. So, we have a working group of immunometrology. So, today's webinar is organized by ATM Immunology Working Group. In this program, we have the topics focus on Rh system and its related topics on this Rh system. So with this, first of all, I welcome you all. Welcome all the participants and the faculties. So with this, I hand over to my colleague, Dr. Mohammad Rafi, who is from Trichur, Kerala in India. So he will be moderator for the program today. So Rafi, please go ahead.
Thank you, sir, and thank you, Atom, for this opportunity. Hope I'm audible. So I would like to request all the participants to keep their mic in mute and video also not to be shared initially. And I'm very privileged to have two chairpersons, our esteemed chairpersons, Dr. Swati ma'am and Dr. Poonam Srivastava ma'am, to be part of this webinar. And first of all, Swati ma'am, she's Assistant Director and the Head of Department of Immunohematology, ICMR, National Institute of Immunohematology. And her main field of interest is immunohematology, molecular biology, and transfusion medicine. She has done a lot of publications and collaborations, and around 101 international and national journals are there. And she has special interest in Rh gene related topic. And our second chairperson for the day is Dr. Poonam Srivastava ma'am. She is the Chief Advisor, Lions Blood Bank, Delhi. She has done training in AIMS, New Delhi. She has established blood bank in ESI hospital. She is an NABH assessor, and she has various fellowships also. So I would like to invite Dr. Swati ma'am to take our program ahead by inviting. She can please say a few words, ma'am. Ma'am.
Good evening, everyone. I hope everyone can listen.
Yes, ma'am.
I actually thank Atom for giving me the chance, and especially to be a chairperson on something which I worked for very long years, that is the Rh system and the current challenges in the transfusion medicine. And I'll be very happy to listen all the very interesting topics today. And I think I think I will also tell Dr. Poonam to introduce herself and start, and then I think we can introduce the speakers.
Thank you, Dr. Swati, and thank you, Atom. Thank you, everybody. Good afternoon, good evening, and good morning. So it's a very important topic which Atom has, a working group has selected for today's discussion. In fact, we face a lot of problems in detection and identification and Rh antibodies. In my experience, almost 70-75% antibodies which we detect belong to this group. And there is a lot of polymorphism and a lot of interest. So we look forward for the deliberations. It will be, I think it will be very, very educative to all of us. Thank you.
Swati, ma'am.
Okay, first, our first topic today is rare but clinically significant Rh phenotypes, challenges and solutions for transfusion. I think Dr. Mustafa is going to present. So I'll just give him CV. He is from Iran, and he is the head of the Iranian National Rare Donor Program and Frozen Blood Department, and he is the head of the Immunomatology Department also. And I think he has got is a member of ISBT Working Party for Rare Donors as well as Immunomatology, and I think he has got a lot of experience, and he has been actually in the Immunomatology Journal, Blood Group, and I think he has been a part of the AAPP for a long time. I think we had last meeting also with him. So his academic career is something very good, and maybe I think he has done a lot of work on rare blood groups. So it will be very interesting for him to listen the rare blood groups, especially of the Rh blood group system and Rh phenotypes. Over to you, sir.
Sir, you can start sharing your screen.
Sure. Thank you very much for kind introduction, ma'am. I'd like to share the screen. Okay. All right. Are we good? Can we see
Yes, sir.
this? Yeah, okay. I'd like to start. Actually, it's an important topic, and I have to admit that discussing about Rh blood group system in 20 minutes, such a short time, is like presenting ocean water in a cup of tea. So it would be very tough for me, especially being among the masters and the experts. So I would say that Rh system is a complex RBC antigen system. Currently, it includes 54 different antigens, and updated terminology is done by ISBT, blood group terminology. You can find Rh antigens and common names in ABB technical manual. Complete names are there, 54. Of course, you see 61 antigens, 7 of them are obsolete. So the tables are there. 5 principal Rh antigens are D, big C, little C, little e. And as Dr. Poonam just mentioned, responsible for about 90% of clinically significant antigens. Many of the antigens are equally common in certain specific ethnic groups. Examples would be X, highest prevalence in Finns, and B and BS in African Black. Of course, in Asian countries, work and study needs to be done to see what are the common variants and antigens. A directory of Rh alleles are kept in website, which the address are there for D alleles and Rhce alleles. Two Rh genes are inherited as codominant alleles. Rhd encodes for D antigen, Rhce for CE antigens, and different other phenotypes. You can see here the figure, different variants of Rhd and Rhce available in technical manual ABB book. The different variants, of course, the weak, the D negative, there are several genetic mechanisms responsible for the absence of the antigen, deletions, point mutation, and silent Rhd, nuance, and so on, that eliminates the D antigens and provides the D negative individuals. D positive, most people are common Rhd protein, have a common Rhd protein, but changes in the amino acid sequence of the protein have resulted in 4 groups. The groups are weak D, partial D, D elution, and non-functional RBC. Weak D RBCs have less than 100 to 5,000 antibody size for detection, because that we do indirect antiglobulin test, but depends on the specific antibody and reagent method that we might get positive reaction and negative reaction. Less antigen is present in that also have big C antigens. They compete. So individuals could appear negative if can be big C in transformation Rhd. So we need to be careful not to miss these kind of with the individuals, the samples, because they might show no reactions, and even though they are weakly, they are antigen G, but very weakly present at the surface, RBC surface. A person who lacks one or more D epitopes can form partial D, can form alloantibodies to the missing portion of RBC D antigen, which is called partial D. Some partial D types are detected with the test, which means of reagent, the type of reagents you are using. So one laboratorian should be careful and make only by the reaction can be seen by indirect antiglobulin test. De-elution, RBCs with a de-elution phenotype is detected serologically by absorption and elution with anti-D and confirmed by genotyping technique. Most of the negative Asian individuals, actually there are the illusion and the Inuit, and there are very, they have depressed antigen D, which they present themselves as Rh negative. Elevated D or D dash dash haplotypes are when the Rh antigens are missing completely or partially. So D dash is caused by mutation that silence Rh big C and big E. D and D-like epitope on Rhce is D epitopes expressed by the protein product of Rh big CE gene in the absence of Rhd. The examples of D, HAR, Crawford in African blacks. Individuals with above phenotypes can be readily synthesized if they are transfused with the positive red cell, since they lack Rh protein. Depends on the type of monoclonal anti-D reagent. You can see reactions as strong as 3+ to 4+, and some other reagents are non-reactive with the others, non-reactive. So my emphasis is that make sure that the type of anti-D available in your laboratory, in your actually market, and make sure you read the insertion and information comes with the reagents. And they need to be kept and referred to anytime there is a discrepancy, and make sure that you get the information. These are the type of FDA licensed anti-D reagents available in the market, which the table is provided in technical manual, very useful. So the antibodies, the main characteristics of Rh antibodies, of course, they are the antigens are very immunogenic outside the ABO system. Little c, D, of course, little c, big E, and E, respectively. Anti-little c may be present at the time that anti-E is identified. If your sample experience shows that anti-E is there, it is most probable that anti-little c is there, or next time, if the patient visits your laboratory, the little c, which was not reacting, this time it would be detected. So it's advisable to provide person who has anti-big E in the sterile little negative blood to prevent any transfusion reaction. It is recommended for sickle cell, thalassemia, and other hematological disorders patients to provide antigen match, complete Rh antigen match, in addition to kill negative. So big C, little c, big E, and little E RBCs should be provided for the patient to prevent Allo immunization. Many altered or variant D, C, and little E antigen can be seen in chronically transfused patient, but they are not recognized, and they are recognized when the genotyping is done for the patient on the sample, or when they produce antibodies which present itself as an autoantibody, and then it is possible that you recognize the variant of the phenotype. D-dash and Rh individual develop antibodies to high prevalence antigens, Rh17, Rh29, and also in warm and drug-induced autoimmune antibodies can to high prevalence Rh antigen can occur in several patients which they have warm autoimmune hemolytic anemia. The standard requires that donors to be tested for VICD expressions, but for the patient, it's not necessary, and it is detecting VICD expression is not actually standard unless testing RBCs of infant of a D negative model. Anti-D6 produced by women with partial D6 has resulted in fetal hemolytic disease. It is recommended that in the laboratory monoclonal IgM with reagent to be selected to be non-reactive with partial D6 RBCs in direct test to classify the negative for the patient as B negative for transfusion or Rh administration. Nearly complete doing actually patients who have RBCs expressing a common type 1, 2, or 3 VICD phenotype, usually they don't make anti-D and they can receive D positive.
So there is some voice disturbance. Can you just have a look at your, there's a voice disturbance.
Oh, not clear, or we get disconnected. Is that what it is? Hello? Are you upset?
There's some voice disturbance when you're speaking. I think there is some loose connection in the mic or something like that.
Let me close it, unmute it, and then go again one more time.
Okay, no problem, sir. Go ahead.
All right. Complete concordance between the genotypes and serologic phenotype disease. Hello? Genotype is complementary to serological results, and the application would be to find compatible rare donors with antibodies to Rh antigen, determines the Rh status of the fetus by amniocentesis. Non-invasive cell-free DNA technique can be used to collect fetal plasma for Rh genotyping, and Rh genotype can complement serologic testing for transfusion, transfused patients like thalassemia, sickle cell, and patients who have positive.
Dr. Mustafa?
Yes.
Sir, there's a lot of disturbance in your audio. Can you please check?
Hello?
I think
Is it?
Whenever
Is it,
you speak, it's a lot of disturbance.
I'm not sure why. I muted my audio.
Oh.
Dr. Mustafa?
Yes.
When you speak, there's some disturbance.
I don't know. I don't know what to do because
you can drop your earphone. That may help.
But I've been in Mokash for as long as I can remember. You know how we got into Mokash? If anyone
is everyone mute? Everyone else.
Processing, sir.
Sorry.
the phone is very good.
The audio is breaking and it's not clearly audible.
I'm sorry. I'm almost to the end. I have my case to present. Or maybe case done. After the second speaker start to talk, and then I'll do the case. I don't know how this to do. Hello?
So do you want to reconnect? We can go ahead with the second speaker.
Yeah, please. Let's go with the second speaker.
Chairpersons?
Hello.
I'm gonna stop sharing.
Yeah.
I think you can stop sharing because it's not at all audible.
I did stop sharing.
So Rafi, can I go ahead? Introduce the second speaker?
Yes, ma'am. Yes, ma'am.
So
Please
you
do.
can share the screen for a second speaker. In fact, it was very interesting case which we had put up and audio was not at all visible. So maybe we will get a chance to later to listen to this case. So meanwhile, I shall introduce the second speaker. She is Janice Hamilton, and she is manager Immunohematology Reference Laboratory, American Red Cross, Detroit. And we know her very well because she has been visiting to us a lot many times as a faculty member of Indian Immunohematology Initiative. And she has wide experience of working in, at least in Indian blood banking scenario, besides her own country. And she's member of various national, international organizations, technical editor, and has a wide experience. And we all have read her articles or her chapters in AABB. So today she will be speaking on variants of Rhe and C, detection and clinical implication. It's such an important topic. When we get just little e, we get in soup what to do, from where to arrange blood. Let's see what she does when she has variants. So Jan, this is your floor.
Thank you. Thank you, Dr. Poonam. It's such a great honor to be here today. I really am going to enjoy being back with some of my colleagues from that region of the world. It's been a while, like you say, but I certainly appreciate this opportunity today, and want to commend the Immunohematology Working Group for the incredible series of webinars that you've put together and the work that you've done to bring these educational programs. Just a quick check-in to the moderators. Dr. Rafi, am I audio
Yes,
and video looking good?
Yeah, ma'am. Yes, ma'am. You have not shared your slide, I think so.
Oh, I thought I did. So let's try again. Oh, yes. One more button to click.
Yes, ma'am. It's okay. You can make it full screen and go ahead.
Okay. So let me just get my people out of here. So again, I'm pleased and honored to be able to present in this setting. I just need to get all my little boxes out of the way. So certainly, as Dr. Mustafa has said, this is a big topic to do in a short period of time, but we'll give it a shot here. I'd like to start just by reviewing quickly the CE protein and the different amino acid substitutions that encode for the little e big E polymorphism at position 226, and the 4 amino acid changes that would differentiate the little c and big C polymorphism at position 103, most importantly, because that's the only one of the 3 that are extracellular. This one at position 16 causes some issues in some of the variants that we see in some of the people that carry these variant alleles. But even though this looks like it's all nice and neatly outlined, the actual requirements for the expression of the 4 antigens that big C, big E, little e, for their full expression on the red cell are not fully understood, even though it looks nice and neat on this diagram. This morning here, afternoon and evening there, I'll be focusing on partial antigens, which are missing 1 or more epitopes and therefore can make alloantibody. And some of these alleles also encode for the lack of other very high prevalence antigens that can result in alloantibody production, as contrasted with a weak antigen where in general all the epitopes are present, and so the patient should not be able to make those alloantibodies. The weaker expression frequently coming from conformational changes. So let's just look at the scope of the issue, and I think it's best illustrated if I refer to the Rhce allele blood group pages on the ISBT website, and these were just updated just a couple weeks ago. So if we look at the alleles that encode for the antigens under discussion here this morning, the little c and the little e, what a variety and what a number of variant alleles have been present. Not all of them at the same frequency, but certainly have been described by investigators somewhere. And this Rhce little e allele is present in many variant forms. 64 alleles are listed in the blood group tables, and a little under half of them are expected to encode for little c, partial little c, or partial little e antigens. But certainly the disclaimer on the entire section is that not all partial antigens may be indicated. So this is just going to be an overview of some of the concepts related to the partial little c and little e antigens, the antibodies they make, and the way that we can work with them in the laboratory. I tried to get a feeling for the potential frequency of some of these Rh variant alleles in some of the populations in your region, and there isn't much out there that has been studied, but we can make maybe some inferences from some of the studies that have been looked at just the frequency of the common antigens, and this just happens to be one recently published one listing the frequencies of the antigens, and most studies published have basically this same relative order and relative frequencies, from which we can, the authors delineated the most common phenotypes and then the most common haplotypes. So my point is that there should be some alleles there, the Rh little c little e alleles, that potentially may have some of the variants, although this has not been directly looked at that I could find. Maybe some people can share their experience in the discussion section. We see most of our Rh variants in our sickle cell population, and almost exclusively in those individuals who have African ancestry. Your corresponding hematologic disorder would be thalassemia, and there was one recent paper that looked at some of the thalassemics. The paper was for a completely different topic, but they did look at the Rh genotyping of their 40 patients with thalassemia from various ethnic groups. At about 25% had at least one variant Rh allele. All of the African individuals, as might be expected, had at least one variant. But if we look at the non-Black patients, there weren't very many Rh variant alleles identified. And in fact, only one allele that's extremely rare might have encode for a partial little c and partial little e, or partial big E antigen. So possibly in the thalassemic cohort, at least the small one in the United States, those alleles may not be very prevalent. So I may be talking about a problem that we have, but might not be seen too much in your populations. So some of the questions that came up in my mind are what are the CE variant alleles that are found in the South Asian and Middle Eastern populations, and exactly how frequent are they found? This frequency would then translate into how frequent is an individual at risk for making the alloantibodies, because you either need to be homozygous for the variant allele or be a compound heterozygote where both alleles encode for partial antigens, partial little c or partial little e antigens. If a conventional allele is in the patient's genotype, then those alloantibodies should not be made. And there are variant CE alleles that are linked to partial D alleles. And so are those prevalent in your populations? And with the possibility of making allo anti-D in addition to allo anti-little c or little e. So getting down to how do we detect these Rhce variant alleles? Well, I'm a serologist, and so I find these in the serologic reactivity that I am seeing in my patients. We may be looking at what looks like a relatively straightforward anti-little e frequently, but the patient's red cells type as little e positive. So the question is this allo antibody or is this autoantibody? And we may come to discover a variant that way. On occasion, the patient's antigen typing might be weaker than expected, and this depends upon the reagents that we might use, but understand that many of these partial antigens do not give weakened typings. And so while I guess we're lucky if we see very weak little e or little c antigen typings that would give us a clue, but that often doesn't happen. And then our patients may not be showing the expected response to transfusion and generate additional study that will result in identifying a variant allele and the corresponding antibody. So sometimes when we have these serologic findings and then we go to genotype the patients, that's when we discover, and frequently that's the first time we have a suspicion that the patient may carry these variant little c and little e alleles. Although more increasingly in my world, in a blood center, we're doing a significant amount of low resolution HEA microarray genotyping of just random donors, or in our world, donors of African descent, because we're looking for those units that we use for just this highly immunized patient population. And through the makeup of some of these commercial platforms, we can identify markers that may indicate that these donors may carry variant alleles. There aren't any of the commercially available HEA platforms, none of them are going to detect all the alleles that encode the partial little c or partial little e antigens. The commercial genotyping platforms don't all target the same Rhce markers. They come at what they're looking for possibly different ways when they have designed their tests. And again, these are low resolution, just looking for potential SNPs or pieces, certain places in the gene where it might give an idea that the donor carries, or the person being interrogated carries a variant allele. Most of them have markers that suggest the most common altered alleles, and these again are ones that are found in the African Black population in the U.S. For example, the 733 SNP variant, the 1006 SNP variant, that may indicate a patient is HRB negative, or the 712 variant that might indicate an HRS negative person. So it's important, if you're using these commercial HEA platforms, that you understand what how the manufacturers have designed them, what they're looking for, and how they are using these markers to potentially detect these individuals with variant alleles. And certainly if you're designing your tests in the laboratory, if you're a molecular laboratory doing these tests on your own, you're going to have to work through this this design and decide what you're going to be detecting as you're designing your test. But in any case, if you do whatever testing is being done for genotyping and you don't see the markers that you have designed your test for, but the serology still suggests this, then you would have to move to a combination of higher resolution molecular methods all the way up to sequencing in order to understand exactly what might be going on in your patient. So what about the antibodies that these patients make, particularly, again, those with little c and little e variants? Well, sometimes it's simple. It may look like the patient has an allo little c or has an anti-little c or an anti-little e, but the red cells type is antigen positive, and they don't react with those antibodies, aren't reacting with the patient's own cells. Rarely, though, is it quite that straightforward. A number of the Rhce little e variant alleles will carry both a partial C antigen and a partial little e antigen. And so the patient could make both of those allo antibody specificities. Although in my experience, it's the allo anti-little e type antibody that you see most frequently. But if they had both of them, that would be a very difficult sample to work with. And then what really confounds things is that these alleles, variant alleles, frequently can encode for proteins that lack other high prevalence Rh antibodies with the potential to make corresponding allo antibody production. So for example, the HRS and the HRB are high prevalence Rh antigens. However, they're not present at all on little e negative red cells. And so that is something that we can take advantage of. However, if we're getting to some of the more broadly antigens that are more toward the whole CE protein, like HR, HRO, or capital HRB, these are not found on those rare deleted Rh phenotypes, and some of the Rh variant alleles will encode for proteins lacking those. And when those particular allo antibodies are produced, then the whole serological investigation and teasing out what antibodies are there becomes very complex, and only being able to be performed with using the most rare cells to tease apart. Patients who can make anti-HRS and anti-HRB, they are found in patients with multiple molecular backgrounds. And when these antibody specificities are listed, you have to be a little cautious because they may not be correctly assigned if those if they were not identified with red cells that are very well characterized for the Rh variant alleles. So you have to know which red cells that you're using, what exactly alleles are present on those red cells, and therefore what antigens would be expressed or not expressed on the red cells. And only then can you correctly assign an HRS or an HRB specificity. And having those red cells for that testing is somewhat very difficult depending upon your cell libraries and your availability. And so some of these antibodies are probably more correctly grouped as anti-little e like, unless you have those very well characterized red cells at the genotype level that can be used to assign an accurate specificity. We do occasionally have some serologic clues. If your patient has an anti-HRB, it can frequently look like an anti-big C little e because any little e positive red cell is HRB positive, normal expression, but it seems that antibody can react stronger with those little e positive cells that also carry big C on the same haplotype. So that could be a clue that this anti-little e like antibody might be HRB. Similarly with anti-HRS, that reacts preferentially with the little c little e haplotypes, and so it can look like an anti-little f if it's not complicated by a number of other broader specificity antibodies. So occasionally you're lucky enough to get some clues if you're observant and you know exactly what you're looking for. So the issues in identifying the allo antibodies associated with the Rhce little e variant antigens are not a few. These antibodies frequently occur in patients who have been multiply transfused. They may have made other Rh antibodies when the patient's red cells type is antigen negative, so they may make anti-big C, anti-big E, as you would expect from looking at their phenotype. They can make an anti-FYA, an anti-JKB, an anti-big S, allo antibodies to other common antigens, and when those are present, that just greatly increases your ability to pick pick through and sort out the specificities of the Rh related antibodies because of the cells that are available to use. The patients, the sickle cell patients that we work with frequently may have warm autoantibodies, and so that complicates sorting through and seeing what the specificity of the variant c or e antigen related alloantibodies. And then when the Rhce c variant alleles are linked to a partial D allele, and the patient has also made an allo anti-D, which you wouldn't necessarily be expecting from just their routine phenotyping, then it just increases in complexity. And the bottom line is the plasma in these patients frequently reacts with all the cells that you're testing, and you have to have some of the very, very rare deletion phenotypes like the HR negatives and the HRO negatives and the capital HRB negatives, the Rh null and partially deleted cells that would be required to tease out these specificities. I have a patient here that just a bit of a case, not super complete. I just want to focus on a few things that illustrate how we might have to go at attacking these patients that have made alloantibodies when their c or more commonly e antigen is a partial, or they carry a variant allele. So this is a patient where we did not do the antibody identification. Another laboratory did in her prior history, but now we're tasked with supplying her blood for her various sickle cell and other medical needs. So this is a patient who her phenotype is common for an African ancestry patient. She is D positive, lacks big C and big E. Routine phenotyping shows her to be c, e positive, and she's made anti-big C and anti-big E. In a current sample that was investigated at that point, the patient's plasma was reacting with all cell tests, and she did have a positive DAT. So we have to go to adsorption studies, alloadsorptions with red cells of particular Rh phenotypes in order to start to tease out what alloantibodies in the Rh system might be there. So we're going to be looking at adsorptions with R1 red cells, c, big E negative cells, with an R2 red cell, big C negative, little e negative, and with a little r cell, D negative, big C negative, big E negative. And we do these 3 separate adsorptions and test the adsorbed plasma separately to identify what alloantibodies might be present in the mixture of these complex patients. So here's one that the adsorption for this particular patient, we can see that the anti-big E that had been previously identified was still reactive because this E positive cell reacts with both adsorbed plasma in which we would expect an anti-big E to be left behind. So the R1 adsorbed plasma and the r adsorbed plasma. When we take a look at the R2 adsorbed plasma, that would leave behind an anti-little e, because the adsorbing cell is antigen negative and therefore that specificity would not be removed. We see that the patient does appear to have some anti-little e related specificity in the face that she's antigen types as e positive. So if I were doing this particular workup, then I might run a few more cells just to see if that e related specificity appears to continue with additional e negative and e positive red cells, and find that it does. So one of the possibilities at this point is maybe it is autoantibody that hasn't completely adsorbed out. We sometimes see a little bit of e reactivity with incompletely adsorbed Rh related autoantibodies. So maybe you do it an adsorption another time, but it doesn't change the fact that the 3 times adsorbed plasma with the R2 cell may still show this antibody with apparent e specificity. So now this is when we start thinking about, does the patient have potentially a variant allele that has allowed an allo anti-e like specificity to be made. If you have the opportunity in these patients to test their DAT negative autologous red cells, as was done here, then you can see that even though the patient's red cells type as e positive, they don't react with this this adsorbed plasma that appears to contain anti-little e specificity. And so that is a hallmark indicator that we need to consider the fact that an allo anti-little e or little e-like antibody might be present. In the investigation of this patient, like I said, that R202 adsorbed plasma did show the anti-little e reactivity. The testing laboratory tested it with some HRB negative red cells, and they were negative. And so it kind of falls into that little e-like category. And then genotype the patient for the Rhce alleles. And this is when the entire picture began to fall together, because this patient was a compound heterozygote. On one side, she was a CE733G, which encodes for partial little c, partial little e. The HRB antigen is either extremely weak or possibly missing, and 2 Rh low prevalence antigens are encoded for by this allele. On the other side, she had a similar but slightly different allele, Rh733G 1006 or 1006T allele, which encodes for just a partial little e, no HRB, and only one of the low prevalence VVS antigens. So having this genotype information allowed the serology to be accurately determined as allo antibodies with apparent little e specificity. When it comes to transfusion, as I said, the HRB and HRS negative cells or little e negative cells are HRB negative and HRS negative. So it'd be great just to be able to pick little e negative R2 cells for transfusion. But in this patient, and as in many other sickle cell patients that we encounter, we can't use these because the patient has already made an allo anti-little e. Frequently prior to the appearance of this little e-like antibody. So these are candidates for transfusion of genotype identical red cells. This of course requires that you have donors in your area that you have also genotyped and identified for their the presence of variant alleles in the Rh little c little e area. So she could receive and would be expected to be compatible and receive without issue red cells from donors who have both of these same Rhce variants. However, it's not always easy to come up with an exact match, and the plasma in this individual was discovered to be non-reactive with Rhce 733 homozygotes. And so that indicates that those patients of that genotype should also be suitable for transfusion, because you're not really introducing anything to her by transfusion that is foreign to her. And that's the way that many of these patients can be handled if you have the donors that are genotyped. Well, so what's the clinical significance of these allo antibodies, particularly in this little e variants? Well, in some cases, they may not be that clinically significant. In some patients, they don't seem to cause increased destruction when just those little e-like antibodies are present. So if the patient has an anti-HRB, and if you give them big C negative, little e positive red cells, they may survive okay. Remember I said that the antibody seemed to react better with the big C positive, little e positive red cells. So if you give them big C negative red cells, then sometimes you don't see increased clearance from the HRB component. Anti-HRS, same way, although in my knowledge, not necessarily direct experience, that the anti-HRS antibodies tend to be a little more clinically significant. But if you get into the situations where these little e-like antibodies are also present with allo antibodies to the broader protein, then that's when the clinical significance greatly increases. So our best case scenario, we like to see patients who are big E positive, because then we are not risking immunization to the big E, and we can give little e negative red cells if it looks like only HRB or HRS is present. If the allo anti-big E is present, then if it looks like these antibodies are clinically significant, then we must consider genotype matched red cells if available. So this information on this slide came from an abstract that was just presented at the ISBT meeting in June. And I thought it was interesting because it's looking at the fact that clinical significance of the antibodies in these people may vary according to which CE allele is present. So it was the investigators looked at 15 sickle cell patients in their population that were homozygous for the Rh variant alleles listed. All of them encode a partial little e, and these patients had been exposed to normal little e antigens. And so it was a small study, but begins to give us some interesting information. So nearly all of the patients, not all of them, made an anti-little e. These two top alleles are HRS negative alleles, and some of them, not all of them, made anti-HRS. In fact, only one of the three made the anti-HRS that was expected. However, that antibody in the patients appeared to cause a delayed transfusion reaction as they were assessing it by the clinical signs and symptoms of hemolysis and anemia at about the time when these antibodies appeared. If we look at the HRB negative alleles, then we have even less allo antibody little e production. Only one of them made the anti-HRB that was potentially their allele suggested that could be made. And it was only one of the antibodies in this HR little CES patient that was associated with a delayed transfusion reaction. So these alleles here with the 733G mutation, sometimes in with conjunction with some other mutations, these seem to be the ones where the patient may not always make the anti-little e or the HRB that would be potentially expected. And even when they do, the red cells appear to have, in this limited series, appear to have normal survival. So I think this is very interesting information. As we gather it more and more about patients in our own population, we can use to make some judgments about when we may need to look for the genotype match red cells if that's available, or at least what to expect in those patients if we have to transfuse against the little e-like antibodies. In terms of the little c variants and the clinical significance of those alloantibodies, the presence of the partial C antigen with the formation of allo anti-little c is much less frequent, so there's less information on their clinical significance. However, the case at the bottom of this slide occurred in the Red Cross system, fortunately not in my laboratory, several years ago, where a very complex patient that was a compound heterozygote for two alleles that lack the HRS antigen. They encode for partial little c and partial little e. The patient had made the little e-like antibody that was expected that might be made, the anti-HRS, and received transfusions without apparent incident. But then several days later presented with what appeared like a delayed transfusion reaction, and then had to receive emergently two more little r units, and developed signs and symptoms of an acute hemolytic transfusion reaction. And after a very, very extensive serologic study, the new anti-little c was identified in both the plasma and the eluate. So these results, when they're on paper, they look like it would be a straightforward, potentially serological investigation, but they, as I said before, are very, very complex, involving adsorption elution with some with cells of various Rh phenotypes, testing of the rare and null Rh phenotypes, and then ultimately genotyping to understand what's exactly going on. So we do our best, but they're very, very complex patients. So that's been just a very quick overview of some of the issues related to the partial little e and partial little c antigens. And I tell you, quite frankly, my head explodes when I try to think about them and try to work with these patients who present with alloantibodies that carry the variant alleles. And so it's just a learning experience every single time we encounter one of those. But I thank you for your attention, and thank you for the invitation to present.
Thank you, Jen. That was excellent presentation. and we can take question answer at the at the end of the session. And I hand over to Dr. Swati to introduce the next speaker.
Thank you, Poonam. And even I would say it was an excellent presentation. I had to just comment that not much of the Rh variant studies have been done in India, but we have done some 1700 patients. We tried to serologically see the reactivity pattern with all those capital C, small c, capital E, and small e antigens with various commercial reagents which are available in the market. And there, when we identified slightly weak reactions or some discrepant results, we tried to do to identify them, and then we tried to do the mutation studies. And actually, we studied some 17 mutations of Rh variants, which are common in the I think in other worldwide population. But we didn't identify any of those mutations. So at present, we are going for sequencing of those samples. So whether we can identify some other variant. So I think Rh variant studies in India are needed. So I felt your presentation was just excellent. And I think maybe we will have more comments at the end of the session. Thank you very much, Dennis. So I think next presentation is Rh immunization in pregnancy, case discussion and current update by Soumya Das. I think Rh is very important in pregnancy. It has been. I actually maybe the Rh blood group system was discovered because of the antibodies produced during pregnancy. And we have come a long way from knowing having the Rh prophylaxis, which has reduced immunization. Then we had postnatal prophylaxis first, then the antenatal prophylaxis, and then knowing the fetal Rh status early in pregnancy was very important. And this has been done by various techniques, which were first invasive, and now they are non-invasive fetal Rh typing. We at our institute have also standardized now non-invasive fetal Rh typing. So I think I will invite Soumya Das to just briefly tell about her. She is MD in Immunomatology and Breast Transfusion from Kasturba Medical College, Manipal. And she's a very young, energetic girl, assistant professor. Now I think she's in AIMS, Nagpur. And her area of interest are immunomatology, apheresis, cellular therapy, clinical immunotherapy, and blood management. And I think she has received many awards. And this I have heard also her many times. And I think she is a bright future immunomatologist from our country. And she's a member of various working party, ISBT working party, and member of various conferences, international conferences. And I think she has some publications in national as well as international. So Soumya, I think you can start. Best of luck.
Thank you, ma'am.
Soumya, you can start sharing.
Yeah. Namaste, everyone. Thank you, Swati ma'am, for this beautiful introduction. And I would like to good morning, good evening, good afternoon, everyone. At the outset, Asian Association of Transfusion Medicine, thanks a lot for providing me with this podium to deliver a webinar. This is my first international webinar which I'm going to talk, and sharing this stage with the stalwarts of in the field of immunohematology is being a great privilege and pleasure on my part to do. So I'll be, this will be the overview of my presentation, followed by, hemolytic disease of fetus and newborn. Basically, we directly jump into that it is caused by the maternal Allo immunization of RBC antigen. But many a time we do forget the non-hemolytic, the hemolytic as such, we tend to forget the non-hemolytic causes as well, which includes the alpha thalassemias, the other non-hemolytic causes, which do needs to be remembered. And because the hemolytic disease of fetus and newborn is mostly due to the maternal Allo immunization against the RBC antigens, however, majority of the focus goes towards the Hdfn caused due to the maternal Allo immunization due to various blood groups. The severity of the same is being determined by either the newborn is unaffected at all or will have just a positive DAT, or it can also lead to a severe anemia and occasionally fetal demise. So before we go into the current update on this topic, I would like to first share a very interesting case which we had encountered in my whole tenure in the field of transfusion medicine. So here goes this case. So this is a mother, a 30-year-old lady with G2, gravida 2, para 1 with one history of intrauterine death. And she was 37 weeks of gestation. Her blood group was A Rhd negative, and she didn't had any history of any transfusion in the past. And her antenatal period was uneventful in this current pregnancy. She gave birth to a male baby. However, within 12 hours of life of the newborn developed severe hyperbilirubinemia with anemia. And this baby was typed as ORHD negative from the peripheral center. The baby's DAT was positive, and the peripheral center also had done a weak D testing, which had turned out to be positive. And since it has a very severe hyperbilirubinemia, the center where the baby was getting a treatment, they gave the child IVIG. But since both the mother's blood group and the baby's blood group were negative, our center received the samples to solve the dilemma, what is going behind. So we went ahead with the mother's IH immunohematological workup. So mother's blood group turned out to be A Rhd negative. The antibody screening was positive, and the mother had 2 antibodies being identified as anti-D and anti-Louis B. So this is the minor phenotyping of this mother. And the Louis B's no further workup has been done, as the Louis B is known to be appears in the pregnancy very often and as a phenomenon called as a Brandman phenomenon. So we directly focused on the anti-D, and the titer for the mother by the serial dilution method was 1:52 with a Marsh scoring of 88, just to have a universal standardization of the titers. We went ahead with the Marsh scoring as well. Now coming to the newborn, which was very interesting to look into. So the newborn's blood group was O with forward was O with A and B cells, and with the anti-D, it gave a mixed field reaction. It had a positive 4+ positive DAT. So in order to proceed ahead, we first did a heat elution, and then we ran the ICT and the antibody identification in order to confirm the specificity of this antibody. And this was confirmed to be anti-D, same which was detected in the mother. Hence, and since the DAT was 4+ positive, we came up with the conclusion initially as the child has hemolytic disease of newborn due to anti-D Allo immunization with a block D phenomenon. And the newborn's final grouping was not given immediately, and we asked the follow-up of this newborn at a 3 months visit. And then when we repeated the blood group of the newborn now, at the end of 3 months, the blood group was O Rhd negative, and the DAT was direct antiglobulin test was also negative. So now we can comment, okay, now the newborn is having a Rhd negative blood group, but why this, even if it has also a DAT negative, but why initially there was a block D or a DAT was positive? So to go ahead with with more workup on this case, we went ahead and did a minor phenotyping on the sample of the infant, and here also it was clear that it was of capital D negative, capital C negative, and capital E negative, and so it is a small r phenotype. Then the question, why the blocking of D was there? So as the peripheral center has also ran a DU test, we also thought, why not to put a DU testing and see. So the DU testing gave a weak positive reaction. Then it clicked to us, why not to run a partial variant D typing panel. So we did a variant D typing panel, and it turned out to be a partial D type 3 phenotype. And what this case showed us finally is the baby had a D variant with a partial D3. The mother has developed anti-D against this particular epitope of the D antigen, though typing wise the baby in newborn is Rhd negative to look into. So the lessons learned from this interesting case is routine blood grouping and screening of ATIP for atypical antibodies during the antenatal checkup, and the correct interpretation of the results in relation to the clinical history and the laboratory finding. It's very essential to manage such kind of cases. Moving ahead, so this case is actually published by our team as a case of severe hemolytic disease of fetus and newborn with variant D mimicking a block D phenomenon. Coming to the current update in the Rh immunization, majority of our focus still remains in and around anti-D. Why? We will just look into it. And Rhd Hdfn is still causes the more severe and the cause of a morbidity and the majority of mortality in case of Hdfns. And since it causes the most of the Hdfns, it is a very common practice in many parts of the developing world to just screen the Rhd antenatal mothers for anti-D. And from lab to lab, the critical titers have been defined as 1:16, which is very much lab specific. And the Rhd immunoprophylaxis has become a boon, which has helped in decreasing the anti-D prevalence. However, it still remains one of the major cause of morbidity and mortality, and the cases are seen approximately 1 to 3 in 1,000 D negative pregnant women. So why anti-D still causes Hdfn? Because the D antigen typing error in the pregnant woman and the newborns, the under-recognized sensitization during a pregnancy. Many of the times it is an inaccessibility to the prophylaxis, a cost factor is one of the major things, or insufficient doses of the Rh immunoglobulin, and the immunization secondary to blood transfusions. We always talk about the Rh. Whenever we talk about the Rh, we always tend to just focus on the anti-D, but we forget the other small Rh family antibodies which are involved in allo immunization very commonly in the pregnancy. Those, one of them includes the double troubles, I call it, is anti-D when it comes with additional anti-D and additional antibody. One common scenarios we get in our labs is when anti-D, when we encounter a pattern of anti-D plus anti-C. We think it is a straightforward scenario. However, it doesn't, it is not so. It goes behind with 5 other possibilities with could be anti-D plus C, could be an anti-G case, could be anti-C and anti-G, could be anti-D and anti-G, or it could be all the three antibodies, anti-D plus anti-C and anti-G. So why we need to differentiate all? Differentiating anti-G from anti-C plus anti-D is a real challenge faced by many immunohematologists. With respective to blood transfusions, yes, there is no need to differentiate them because we will be giving them small d, small c, and small e blood. And however, with respect to the pregnancy, the administration of Rh immunoglobulin will be based on the presence or absence of anti-D only. And suppose a mother is Allo immunized with anti-G or anti-C and anti-G cases, then very safely we can prevent the anti-D immunization by providing the mother with Rh-Ig. And it also helps us from preventing from the social and medico-legal complications. Coming to few non-D cases, the prevalence of red cell antibodies other than anti-D with the potency to cause Hdfn is approximately 1 in 500 pregnancies. And the other antibodies which are associated with a high risk of Hdfn, especially in the Rh family, includes the small c, which has the highest risk after anti-D, the capital E, which has a medium risk, and all the other Rh antigens have been associated with medium risk for disease with incidental severity but mostly mild disease of Hdfn. So a bit on anti-small c, it is the most common cause of severe Hdfn after anti-D among the Rh family. And the titer is 1:32, what we take into account. And the British Council has given guidelines stating that retesting the woman with Allo anti-C is in a similar manner as followed for anti-D, that is at least monthly till 28 weeks of gestation and every 2 weekly thereafter. And anti-small c is known to cause delayed anemia in the neonate.
Excuse me, Dr. Soumya, can you just hurry up a little bit because we are running late. Sorry to interrupt.
Okay, ma'am, I'll do that. So coming to the, so with this background, so why we need to test during a pregnancy? First, in order to prevent the Rh Allo immunization, then coming for monitoring of pregnancy, anemia, pregnancy management, and neonatal monitoring, and for management further. So this is a beautiful chart guidelines which is being available from the ABB side, and more or less the British Association, the Canadian and the Australian more or less follow the same guidelines, which states that the ABO and the Rh typing needs to be done at the initial visits and with the subsequent pregnancies as well. And for the unexpected antibodies, we need to screen them in all the pregnancies. And once we have detected something, we need to identify them. And titration based for Rh, it is to repeat at 18 to 20 weeks, and for the others it will be at 2 to 4 weeks interval. And it is very much in place that it is essential to screen all the mothers irrespective of their Rh status. However, in developed countries, the screening guidelines for screening are yet to be in place. So this is few of the data from the red ones are the highlighted ones, which are from the Southeast Asian countries, and a good amount of literature is being coming up from this part of the world as well on the Allo immunization with the pregnancies. So we first need to identify the Allo immunization risk, and with the natural, with the history, proper history, and we need to identify the sensitizing event which can cause Allo immunization in a mother. And so this is a flowchart which labs can follow in order to do a workup on the antenatal cases, which goes by screening followed by the identification, and in order to confirm that, followed by minor phenotyping, antibody titration, then monitoring the fetus with fetal Doppler, and for the newborn, a direct antiglobulin test, followed by confirming the specificity of the antibody with elution techniques. Now coming to how do we tackle the Rhd variants if we encounter in our lab setups. So if it is a D positive, which we are getting a strong positive reaction, then go ahead, report it as positive. But suppose you are encountering a 1+ or a 2+ reactivity, it is better to label them as Rhd negative, as they may have a weak D or partial D status. And further, we need to do them genotyping in order to administer for anti-D. Reporting of the same antibodies, clinically significant antibodies, we need to follow the same workup. And for the clinical insignificance one, we do need to inform the clinicians accurately regarding the significance of these insignificant antibodies and that they interfere with the scenarios. Now coming to the monitoring, so we need to quantify the antibody and the perinatal determination of the fetal blood groups, which is a major new current, which is an update in this field. So coming to the quantification, it determines the strength of and the concentration of the antibodies, and it helps the obstetrician to monitor the fetal anemia. Now, a rising titer of 2 tubes or a critical score of more than 10 is considered as a significant change, and we need to monitor them accordingly. And once the critical titer is being reached, there is no further titration needed. It is mostly lab specific, and it is mostly determined that no perinatal death have happened. The best method to do it is by column agglutination conventional tube technique till date. And how often to do that? 4 weeks, every 4 weeks until 32 weeks, and then for subsequently every 2 weeks. Coming to perinatal fetal blood grouping, it is being widely used these days in Western world that maternal blood samples, fetal red cell antigen genotyping is being done. So if the antigen is positive, the fetus is at risk and ongoing clinical monitoring needs to be done. And if it is antigen negative, then routine pregnancy monitoring is sufficient. For the genotyping, for amniocytes or the CVS can provide similar predictive information, but the problem is that there is an invasive strategies with the risk of fetal loss. Hence, the new technique of cell-free DNA testing is being implemented and has shown to be a cost-effective strategies in various parts of the Western world. So what is cell-free DNA? So 10% of all the cell-free DNA is in maternal plasma is of fetus, and they are detected as early as 4 weeks of gestation, and they're plentifully available by 10 weeks. And their major source is from the placenta, and it is ideal to test it at 24 to 26 weeks of gestation, and they have shown to have 99.9% sensitivity for detection of Rhd positive fetus. They have been also being used to detect the status of Rhd, small c, capital E and Kell status using the mother blood group sampling, and they can guide in the perinatal management. Next thing is the fetal, which is the MCA PCB, which is the current gold standard for screening for the fetal anemia, which measures the blood velocity of the middle cerebral artery. And it determines the severity is defined as multiples of median in the as per to the gestational age of the mother. Coming to the Rh Immunoglobulin Recommendations, if Rh negative with no anti-D at the first perinatal visit, then repeat the screening and administer Rhig at 26 to 28 weeks. And this timing relates to the increased likelihood of fetal maternal red cell exposure in the last 12 weeks of pregnancy. This strategy has actually helped in reducing the Rhd Allo immunization drastically up till 0.016%. A new strategy of targeted routine antenatal anti-D prophylaxis, which states that all the Rhd negative mother with no anti-D are eligible for Rh immunoglobulin, And because there is almost 35 to 40% of the Rhd negative mothers carry a Rhd positive fetus. And routine maternal blood sampling for fetal Rhd genotyping early in the second trimester will help in prediction of the fetal Rhd status. And if the fetus is negative, no antenatal Rhig is required. If it is positive, we need to administer the Rhig. The genotyping has also been implemented in Rh negative women with altered Rhd expression. That those are the D variants, and also that will determine whether we have to give the Rhig or not. For adequate dosing, it is ideal to use the Claire-Bedke test and or the flow cytometry test if there is a sensitizing event of FMH after 20 weeks of gestation. Coming to the treatment entity, for the antenatal part, for the fetal, there is intrauterine transfusion, the age-old thing which is still going on, the maternal, IVIG, plasma exchange, and the monoclonal antibody, which I'll just briefly tell a bit, and plan the delivery between 34 to 37 weeks. Postnatal, there is delayed cord clamping and manage the neonatal anemia with top-up transfusions, watch for transfusion-related morbidity, and manage the neonatal jaundice and phototherapy, exchange transfusion, and IVIG as well. So coming to the new treatment tools which are being used as a part of the maternal therapy, certain immunosuppressants like azathioprine, promethazine, and prednisolone are being used as few of the current candidates, because the principle goes behind this is we need to suppress the immunological response to the foreign antigen, and this is being used in cases who are heavily allo-immunized mothers. Next, a new drug is a monoclonal antibody M281, nipocalimab, which binds to the neonatal Fc receptor to inhibit the transplacental IgG transfer, and which is being launched as a multi-center open-label trial to check its efficacy. Two slides on the transfusion support. The best approach for these to prevent the Rh immunization is give extended antigen matching of the RBC is the only way to reduce the transfusion associated alloimmunization in the future. But this policy has have a cost and resource implication. Then group O, low titer hemolysin or ABO identical with the fetus if known, and RhD negative blood. And it is mandatory to do a IAT cross match with maternal serum and negative for relevant antigens determined by the maternal antibody status. The role of rare donor program. So ABB states that infants with Hdfn resulting with multiple antibodies or an antibody to a high prevalence antigen, the mother, if is ABO compatible, can be considered as a logical donor, or use the family screening in order to find for the rare groups. So to conclude, for all the Rh immunized pregnancies, it is ideal to have a timely diagnosis for better fetal surveillance and prevent the morbidity and mortality. We need to identify the need of Rh immunoprophylaxis to prevent the antibody formation, identify the fetus at risk for the risk of Hdfn by screening for alloimmunization. The laboratory report should direct the clinicians ideally when to send the next sample and which patients have a potential fetus have a potential risk. A good thing to end with, that modern management of red cell alloimmunization and alloimmune fetal anemia is being a success story in case of the fetal medicine. Over the time, we just need to refine our care with the advanced techniques being applicable in this field. To acknowledge few people, thank my alma mater for having this case of D variant with block D phenomenon, and both the co-speakers for sharing the data from their countries as well, that how the scenario of Rh immunization goes on in this field of whether the obstetricians are using routinely the screening for antibodies or not. Thank you. And last but not the least, my center for giving me all the permissions to do this session. Thank you, everyone. Thank you for your time. I will be happy to take some questions.
Thank you, Soumya, for a very good presentation. I think time is lacking. Should we go for the next speaker?
Yes, ma'am. Time we have
Dr.
already
Poonam,
told.
can you introduce?
Yes, thank you, Dr. Swati. Because of time shortage, the topic is so good. You keep on, you want to listen everything, but because of shortage of time, we have to cut short. And I will introduce next speaker, Dr. Mustafa Elawarti. He is from Muscat, Oman, and he is PhD in molecular immunohematology, and he has a molecular background of serological D negative in Omani population. He has various positions in College of Health Sciences, has earned many awards, accreditations, and publications. So Dr. Mustafa, welcome. And because of shortage of time, I request you to be a little bit fast. Thank you. Welcome you here, Dr. Mustafa.
Thank you. Thank you very much. Thank you very much, Dr. Poonam, for the introduction. And I would like to thank the organizers as well for the invitation. I will start straightforward just to save the time. So this is a case of a novel DBS zero-like allele, all right? And to start with, I just go through the basics of the molecular biology of the Rhd gene and Rhce gene. Now, as you can see over here, that Rhd and Rhce are both almost similar to each other, but they are in opposite orientation to each other. They are found in chromosome 1, all right? And both of them, they have 10 exons, but as I said, they are in opposite orientation to each other. And as Dr. Jan also mentioned in her presentation, that now each of the genes, it will produce a protein, which is the antigen itself, and that will give the Rhd antigen or the Rhce antigen. And the difference, of course, the main difference between big C and little c is amino acid 103, and the main difference and the one difference between the polymorphism, of course, between big E and little e is amino acid 226, and both are found actually in extracellular domain of the protein cell. So that's why it will give a different phenotype. And of course, now they are actually co-dominant, all right? So Rhce can either appear as Rh big C big E, or Rh little c big E, or Rh big C little e, or Rh little e and little c. So to define the D positive and D negative, as far as D is concerned, there are many pictures that I want to show you how we can define the D positive and D negative. Now, having said that, now the presence of the Rhd gene as a first scenario, it will give Rhd antigen protein, all right? And that will give Rhd positive phenotype. That's fair, straightforward. Scenario 2, where there is Rhd gene, but there is no Rhd antigen production, all right? Though there is Rhd gene, there is no Rhd gene antigen production. So this is Rhd negative. And one of the reasons of that is the silent or inactive gene. You can see. So gene is there, but it is silent or it is inactive. So that's why it cannot show as a phenotype. Scenario 3, there is Rhd gene, there is Rhd antigen, but when you do a serological test, as I think one of the cases Dr. Soumya showed that serologically it's Rhd negative, but the gene is present. So this is where you can see in few types of D variants, and that is one of them, the partial D, D3 type, which you have, which Dr. Somia exactly shown you. Now, the case for or scenario for when there is no gene at all, RhD gene, and there will be no RhD antigen, and therefore there will be no RhD, and the phenotype will be RhD negative. So, I talked about D variants actually. Okay, so there are two molecular mechanisms behind these D variants. Now, these D variants can be seen due to one nucleotide change or few nucleotide changes. So as you can see here, we have the RhD gene with 10 exons. If you can see this red line, so there is one nucleotide, one polymorphism we call it, one nucleotide change, and there are here maybe several changes. Okay, so what does that mean? All of these, maybe they can give a partial D, they can give a weak D, they can give a del phenotype as well. Okay, so if it is a partial D, the partial D, it's going to affect the quality of D antigen. So it's not going to, it's going to be the epitopes of the D antigen, which will be affected. Now, if we talk about weak D or del phenotype, so these phenotypes affect the quantity, the number of D antigens will be less. So this is first mechanism. Let's go and see the second mechanism. So second mechanism is where when the RhD exons are replaced with Rhce exons. So as you can see here, it can be only small part of exon of the RhD, which can be replaced by Rhce, as you can see here. It's the white line, or the full exon, as you can see in D3b, or it can be several exons, as you can see in D6 partial D. So all of that, if there is a replacement or rearrangements of the RhD exon, then it's replaced with Rhce, then that's called a partial D, or we call it hybrid RhD CED. So that's why we say you have RhD, as you can see here, RhD with little of Rhce, as you can see here, and then again RhD again. So this is the partial D type 2. So partial D can either raise because of the Rhce hybrid or because of the nucleotide mutation. So of course, if it's a partial D, then it's going to affect the quality of the antigen on the red blood cells. So this picture I have taken actually from Daniel's article, which shows different partial D with rearrangement of the exons and replacing that with Rhce. As you can see, the Rhce is presented in white box and RhD exons in black box. Now, one of the things which I want you to just bear in your mind that each partial D is associated with a specific Rhce haplotype. So it's like if you are dealing with D3A partial D, then it could be associated with small c, little c and little e of Rhce. And the same for the D5 partial D, it will be associated with big C and little e. So the haplotype will be as you can see. So let's talk about now DBS0, which is actually D5 type 3 partial D. So it is a partial D, and what type of partial D? It is a hybrid partial D where there is RhD. It is RhD along with Rhce in exon 5. The change is in exon 5 with only 3 or 4 nucleotides within this number of the nucleotides. And of course, then it comes again the exons of D. And this is what you can see here. Okay, so you have 4 nucleotides, which gives, of course, a different protein with 4 amino acid changes here. All right. So one of the amino acid changes, as you can see here, this is typically, as Dr. Jan said, so this is a mutation for E antigen, big E antigen. So a big E antigen has come across in the D gene. Okay, so E gene or E allele, it came along with the D allele gene. So the haplotype in the DBS is actually big D, big C, and little e. It's not actually big E. All right. So the PCR can show you big E. The PCR testing is going to show you big E. Why it's going to show you big E? Because of the presence of the Rhe allele inside D gene. But actually, if you do the transcript analysis using messenger RNA, all right, it will show you that there is no big E, but there is a small e allele only. So that's why the haplotype in this case is actually small e, but not big E. But because of the presence of big E gene inside the RHD gene or exon 5, that's why it is going to show you in the PCR. So serologically, you will see a partial big E in case of DBS 0, all right? But our case report is actually in order to find out the molecular background of serological D negative in Omanis, because we were looking for the molecular background of Omanis who are D negative, okay? So this is a 46-year-old male non-RHD negative donor. He is very well known to be RHD negative, all right? And this is what the gel card showed us. So it is clearly D negative with big E negative, all right? With others, big C, small c, and B and small and big C and little c and little e positive. We did, of course, a weak D testing, all right? And it came to be also negative. So this is big wheat negative, and that's the DAT testing as a control to just avoid any false positive in D weak testing. And then we used a partial D badging kit to determine what exons we have for the D antigen. And what we found here, we found that there is a lack of exon 5 here of the RHD, and there is a lack of exon 8 here. Okay, so there is no amplification of exon 5 and exon 8. So we run also a single-plex TACMAN real-time PCR, and as you can see here, that we run a positive control, and this is the sample where it showed a clear amplification of exon 5. Sorry, I'm just talking about exon 5 here, about RHD exon 5. All right. So, when we run a gel to just confirm our result that this is expected band which we are getting, and we were expecting actually 82 base pair band, and this is what we have seen. So as you can see, this is positive control. We have seen 82 base pair band, and for the sample 82 we have seen also the same band. So there is amplification of exon 5 with the single-plex PCR and no amplification of exon 5 in the partial D type, of course, the badging kit from the Germany partial D type. And then we also tried to use the badging kit to find out the RHC alleles, RHCE alleles. And what we have found here, as you can see, we have found big C, little c, big E, this is big E, little e, and no, of course, big C, W, and there is no band over here. Okay, this is all control, as you can see here. This is all controls. So what is the conclusion here? So we are having a big E extra additional here. So our conclusion was this. Is this a DBS0 like, is this a DBS0 allele? Are we dealing with DBS0 allele? But further analysis now here. Now in badging kit, let's try to, first of all, to analyze our results, to explain the results. The badging kits had no amplification. With singleplex Tegman real-time PCR, there was application. And the reason for that, badging kit was using allele-specific primer where it was targeting nucleotide 667. And this nucleotide 667, okay, is a place where there is a mutation, where it is where the D gene or the exon itself is mutated, or there is a polymorphism over here. So that's why there is no amplification in this kit. We didn't find any amplification because of the mutation in the gene itself. But we use a singleplex PCR, a specific primer, where it was targeting nucleotide 654, where it successfully amplified exon 5, and that's why we got exon 5. So, and another question which came to in our mind, why serological it's D negative, not D positive even? All right, so is this a partial D? Actually, DBS0 is a partial D. So why we are not getting it as D positive? The reason is this: we used, of course, in the gel card, we used the anti-D diaclone, BioRide anti-D diaclone which is for weak D testing. And when we read the insert kit, so it was clearly mentioned that it was evaluated only for D5A, but not D5 type 3, which is DBS0 here. So we assume that this type of reagent is unable to detect this the DBS0 partial D. All right. So what is the similarity between the DBS0 and the case which I presented? Both amplified Rhe allele, as we have seen in our case, and also what have been seen in the literature before. What is the difference here? We found serological big E negative, okay? And because we haven't seen also exon 8 amplification, if you remember my previous slide, okay? So this is more probably is associated with DAR allele as well, okay? So there are two mutations over here, okay? So that is with the badging kit. But of course, in DBS0, we usually, according to the literature, we supposed to see partial big E. So our case is quite different here. We don't see any partial we didn't see big E antigen. So that was what we predict in this case, that we have Rh big E allele within the Rhd, and there is a mutation, okay, causing along with that, there is a mutation causing the DAR phenotype as well. So we have also thought this is maybe a hemizygous where we have one gene, okay, one from one one parent having what I have already explained, two types of mutations, DBS0 and Rhdr. Yes, please.
Please finish a fast.
Yeah, it's just one slide, one more slide. That's all. Yeah. Sorry, huh? Yeah. All right. Okay. All right. So there is no change in Rhce gene. Okay, it's as it is. And the second gene, okay, it's the full deletion of Rhd. So we are dealing with, this is called the hemizygous, where there is one deletion and one gene deleted and one gene is mutated, as you can see. So this is, we thought, because there are quite differences, so this is actually a DBS0-like allele. So this is a possible DBS0-like allele exists, as serological E negative was observed with the Rh big allele existent at molecular level due to hybrid RhD and Rhce. And messenger RNA transcript study would further explore this case, and molecular basis of dizygosity also would confirm the homozygosity, because I said we are assuming this is a hemizygous, but it could be also a homozygous, it could be also double heterozygous. So we need to do a dizygosity testing to confirm that. So these are some references which I have used for the case, and thank you very much. And you are most welcome for any question.
Yes, thank you, Mustafa. It was such a nice presentation.
Thank you very much.
very well analyzed case. But because of shortage of time,
it's okay.
Yeah. So over to Dr. Swati for next presentation.
Yeah, even I would agree. It was an excellent presentation, but I think because of short of time, I cannot comment much on this. But I love the presentation, especially for the molecular level and how you did various techniques and how you could find things. So I think maybe we'll discuss it afterwards. So the next presentation is for D phenotype due to RhD, Rhce hybrid transcript, a case report. So this is on the rare Rh phenotype D and I think this Anila is presenting. And I think the molecular typing for this phenotype, I think we have done in our institute. And Anila is a very bright student, MD in transfusion medicine from Sri Chitra. I think she is Dr. Debashish Gupta's student. And now I think she has joined All India Institute of Medical Sciences at Mangalgiri, Andhra Pradesh. Congratulations for that, for your new venture. And I think she has received many academic achievements. And she was, I would call her my student because she had attended our training program and she was with us for nearly a month. So bright student. So I think, over to you, Anila. I think you present.
Thank you so much, madam, for that kind introduction. So good afternoon, very warm good afternoon and good evening to everybody. So first of all, I would like to thank the organizers and coordinators of this AATM immunohematology platform for giving me such a great opportunity to present it to this global platform. So I'll straight away go into my presentation.
Please share your screen.
Yeah, sure, sir. So I'm today discussing about D phenotype, which we have accidentally encountered during a routine immunohematological workup for a severe Hdfn case. So this I have encountered when I was in Kerala, when I was in Sri Chitra Institute. So this is a brief discussion about D phenotype which we have encountered. And we got this published in coordination with the National Institute of Immunohematology, Mumbai, along with Swati madam recently during June 2021. So before going into the much in detail about the case, this is just about a very brief introduction about D-. Already it has been well mentioned in the previous presentations. So as we all know, this is a rare Rh variant, and here what happens is that none of the Rhce antigens will be expressed. Only D antigen will be expressed, and it was first described in 1950s. And since there is the absence of Rhce proteins, which is coded by the Rhce gene, D antigenic expression will be so much enhanced to such an extent that there will be an exhausted D phenotype. So the individuals who are having this D-, phenotype, the significance is that they can produce this anti-Rh17, which is a highly potent Allo antibody, which is directed against all these Rhce proteins like CCE antigens. So, and this is a highly immune antibody, which is of IgG type, which occurs in people who are sensitized during pregnancy or transfusion, and it has got the potency to cause severe hemolytic transfusion reactions and Hdfn also. So, coming on to my case and proper. So the case history is like this. So we have encountered a 33-year-old second gravida who had parity was one. There was a live-born child already. There was no history of any previous abortions. So she was brought to the obstetric casualty at 38 weeks of gestation following premature rupture of membrane. And she was a patient who had regular antenatal visits in the peripheral center, and the antenatal period, as per history, was completely uneventful. There was nothing like an anemia, or she never received any transfusion support during the pregnancy also. So owing to the yellowish stained liquor at the time of admission, it was misinterpreted to be a meconium stained liquor, and an immediate cesarean section was also planned for her owing to fetal distress. So after the cesarean section, baby was born, male baby with a birth weight of 2.74 kg was born with features suggestive of severe hemolytic disease of fetus and newborn. So routine blood investigations were carried out on the cord blood sample. It revealed hyperbilirubinemia with a serum bilirubin of 17.4 milligram per deciliter. There was anemia, and the hemoglobin was 9 milligram per deciliter. Peripheral smear showed all features of hemolysis, like fragmented red cells, nucleated cells, reticulocytosis, and the retic count was 25% at that point of time. And the sepsis screen of the baby was negative. So initial management of the baby was carried over with quadruple surface phototherapy, which was followed by IVIG infusion, but it was inadequate, and the anemia and hyperbilirubinemia was not much recovering. So they have done one top-up transfusion with 40 ml of blood group compatible packed red cells. Here, we are supposed to check the compatibility with the maternal serum. Here, what we found that the maternal serum was incompatible with all the red cells which were available. So the only possible way to get a cross-match compatible blood was to cross-match with the baby's own serum. So that's how we got this unit. And the transfusion was carried out on postnatal day 3. Gradually hyperbilirubinemia, anemia, everything improved with rising hemoglobin values, and the baby was discharged. So as a part of routine Hdfn workup, samples were sent to us for Hdfn workup. So once the sample has reached to us, we first sought a proper obstetric, previous obstetric and a medical history. So this is how it was. There was a striking feature. The parents of the lady, the mother of the particular baby, they were a consanguineous couple. And the lady, the propositor who had this Hdfn baby, who already has got a 6-year-old female child, which is as a result of a non-consanguineous marriage, and there were no history of any previous abortions. So the previous pregnancy also, the antenatal and the postnatal period was completely uneventful, and there was no history of previous blood transfusions during antenatal or after childbirth period during the first pregnancy and childbirth. Then the medical history. So the particular lady, the propositor, she has suffered carcinoma of breast around 3 years back before delivering this baby, and she has undergone a modified radical mastectomy, and she even underwent chemotherapy for 1 more year. So, but there was no history of any blood transfusions during the surgery or the chemotherapy. So then this is about the immunohematology workup which we have carried out. Routine forward and reverse grouping of the mother, baby, father, everybody was done. Then direct antiglobulin test and indirect antiglobulin test was done. So this DAT of the baby came to be positive. And for the mother, that was negative, but her IAT was strongly positive. So we have run an antibody screening and identification for the maternal serum. So we obtained pan-reactivity in both Rhce and 11 cell panels. As you can see here, this is how the 11 cell panel looked like, which gives almost same grading of reaction for all the 11 cells. Then we have subjected the elevate. We have subjected the red cells of the baby acid elution. So we found that the elevate is also giving the same reaction pattern as like the serum, maternal serum in the 11 cell panel. So here you can see the Rh extended phenotyping of the mother. So here we can see that she's negative for capital C, small c, capital E, and small e antigens. So this is how we got the suspicion that this can be a D-, phenotype, where we had to proceed further with adsorptional elution studies, which confirmed the absence of CZE antigens further. So since this D dash individuals they are potent to produce antibodies against all the proteins which are coded by the Rhce gene, we could conclude that the cross reactivity or the reactivity in all the 11 panels are due to that. And we found out that from our panel, there was no panel among these 11 cells where at least one of the CZEE antigens were absent. So we got everything to be pan-reactive. So then what we have done is that we have brought back the family members of the lady, like her husband, her first child, then all her family members like mother, father, and she has got one more sibling, one more sister. So for everybody, we have done blood grouping and done extended phenotyping. So this is how the blood group appeared to be. We can see here the blood group of the lady. Her newborn and the first child was ARHT positive, and for the husband it was ORHT negative. And parents and sibling, father and mother of the lady, they were ARHT positive, even sister also. So then we have done an RH extended phenotyping for everybody. So we could find here that the husband of the lady, he was positive for capital C and small c antigens. Exactly like the father, both the children, they got positive for the C, capital C and small e antigens. So, and the father, mother, sister, everybody, they were also positive for capital C and small e antigens. So this is how we could conclude that she might have got sensitized from the first baby intrauterine stage itself to this capital C and small e antigens, which led to a severe Hdfn in the current pregnancy. So like expecting this to be a case of D phenotype, for further molecular workup, we have sent the samples to ICMR, National Institute of Immunohematology. So this is how the molecular workup has proceeded. To understand the complete molecular basis for the which has resulted in the absence of this CCEE antigens from the red cell surface, the technique which was used was a quantitative multiplex PCR. So, and the PCR SSP, single sequence specific primers, it confirmed the absence of CCEE antigens, all the proteins which are coded from the Rhce gene. So the molecular mechanism which was responsible for the D phenotype in our case was, it was identified to be a molecular rearrangement which has resulted in the replacement of the coding sequences of this Rhce gene with Rhd gene. And for us, we know that the Rhd and Rhce both are having 10 coding exons. So in our case, for the Rhce gene, 3 to 9 coding exons were replaced with Rhd gene, so that the Rhd gene had its own function from the Rhd gene, and also this newly inserted gene which led to the production of an exalted D phenomenon, but Rhce became silent here. So this was the mechanism which was found out in as the cause for a D phenotype in our study, and this is how the family study or family genotyping has resulted in. The lady, she's homozygous for this D and so that she became a dominant expressor for this D phenotype, and both her parents, who were consanguineous couples, they are having a single non-functional copy of these D haplotype, and both of the children of the lady, they became carriers for this D haplotype. So this is about a short discussion about what are the mechanisms which can result in a D phenotype. So it can either be a complete deletion of the Rhce gene, or it can be just a replacement of the Rhce coding sequences, as like our case, by the Rhd gene, or it can be single nucleotide polymorphisms, or it can be lack of the CCEE antigens as a result of reduced transcriptional activity, or as a result of an integrated gene deletion of the Rhce gene. So whatever it is, there will be an Rhd Rhce hybrid which will lack the antigenic expression for the CCEE antigens, and the replacement of the Rhce coding regions by the Rhd gene, it's otherwise known as a deletion haplotype, where the Rhd occurs to be in the cis position. And in our case, we have confirmed the reason for the D phenotype to be Rhce, Rhd, Rhce hybrid with 3 to 9 coding sequences of the Rhce is replaced by the D gene. And same mechanism has been reported as the most predominant mechanism, which is responsible for D phenotype by Indians in a recent study published by Dr. Swati Kulkarni, Madam and Co. In 2020. So this is exactly the same mechanism which we could find out in our case also. So this people who are having such a phenotype where none of these Rhce gene proteins are expressed, they are potent to produce anti-Rh17 antibodies, which is a very potent antibody which can result in severe hemolytic transfusion reactions or Hdfn. And even the severity caused by this anti-Rh17 is more as compared to anti-D or anti any of the other Rh antibodies or even Kell antibody as from other studies. And in our population in India, this is not that kind of a common phenotype, but in Japanese studies, they have reported a very high prevalence of D phenotype of almost 1 in 1 lakh in their population. And they have even reported more than 50 cases of severe HDN as a result of anti-Rh17 antibodies, which has resulted in many like prenatal and postnatal mortalities. So as a transfusion medicine specialist, what we have to do, what next we have to do, that is our main concern when we are encountering with such kind of rare haplotypes. So once identified, these individuals should be enrolled into our rare donor registry. So it's not just to make them a rare donor, it's for the purpose of making them donate for themselves also. It's not just for donating for other individuals, but at times where there are donors who can't donate for themselves, just like our study where she has got a malignancy history, so she can't donate for another person. So such type of scenarios, even though autologous donation is not advocated if a patient has got a malignancy history, other people who are fit to donate, they can be planned for patient blood management strategies also to minimize their blood flows rather than going and searching for a donor, especially in this kind of scenario where it's very difficult to find out a donor who is compatible. So there are many studies which have published cases of this D phenotypes. Those patients have undergone multiple surgical procedures also with the help of pre-deposit autologous blood collections or intraoperative cell salvage modalities. So rather than making them subject to an allo transfusion support, we can make them subject to autologous transfusion support also. So this is to conclude. So such sort of rare phenotypes like D-, especially if allo-immunized, they are of great concern at times of transfusion requirements, especially if it's an emergency case, we won't be able to find out the donor at that particular point of time. So what we can do is that we can first of all make a family study and we can make somebody donate from their family if we are able to find out a group match donor from the family member itself. So family study is very important for such kind of rare phenotypes. If that's not available, then we have to search in the rare donor pool, or we might have to do like blood salvage modalities. So this is how we proceed with. And there should be a proper identification of all these individuals also, not just to contribute to the rare donor pool as I've mentioned, for the purpose of patient blood management strategies also. And there should be an effective collaboration of national and international rare donor registries also that should be established to adequately mobilize the rare blood units across the globe at the time of requirements. Then we need to reinforce more patient blood management strategies like pre-deposit, autologous pre-deposit, or intra-op cell salvage modalities, or blood salvage procedures like preoperatively we can give like stimulated erythropoiesis with erythropoietin, or we can reduce the blood loss by giving tranexamic acid. All those modalities can be planned for this kind of rare situations. And it should be made mandatorily to test for all antenatal cases in the first trimester itself, an indirect antiglobulin testing, which is irrespective of the RHD status. So this is what we have missed in our case. Even though the lady was being on regular antenatal monitoring, her IAT was never checked during the antenatal phase because she was RHD positive. So it should be made into practice, not just for RHD negative women, RHD positive people, Rh positive women also need to be screened for this IAT at the antenatal stage itself, so that if you want to intervene, we can intervene at the earliest. So this is all about my case. So thank you for the patient listening. Thank you so much.
Thank you, Anila, for a very good presentation. I think we have to go to the first lecture again. We have to complete that lecture. Dr. Poonam?
Yeah. If we,
Yes, sir. Mustafa sir, can you? Yeah,
time?
Mustafa sir, can you try logging in,
Yeah.
Mustafa sir?
I rather, to the interest of time, decline and put it for a better, suitable time to present the case. Even though the slides are there and the case is, can be accessed in the site. So it's been a long session. If you agree, we'll do the
Madams, you can decide.
Dr. Rafi, how much time do we have? Can we
Like,
give 5-7 minutes?
Yeah, no issues, madam.
No issue. So Dr. Mustafa can present in a short. You can be quick and present. We would listen to you. 5-7 minutes.
All right, let's
Is
go.
that okay?
I think sure. I think he should get the time to present.
Okay, this is actually a case which was discussed in the ISBT Rare Donor Working Party last month. There was a request from a physician in Australia for a pregnant woman which was due to deliver in 9 weeks. The point was that the gynecologist needed the blood just in case. So this is gets like sometimes complicated once you have a rare blood type from a patient. But the case was presented in the working party to request to get help for the rare blood type. So the patient type was O, Rhd variant, antibody screen positive, antibody was identified as anti-D, E, anti-HR, anti-HRS. The titer of the antibodies with cells R2, cells were titer 16, which actually the antigens are a big E, HR, high frequency antigen, and HRS, which was explained by the previous speakers very nicely. And the titer of HRS antigens with leader R cells, leader R cell was 2. Okay, the next slide. With the bioarray system genotyping technique, the phenotype of the patient was determined as being DAR, CEAR, CEER, and as if like it is similar to anti-F, but this is in a and actually in a patient which it could be from minor ethnicity. The treating physician requested 2 fresh units, if possible, from donor with the same genotype as the patient. The blood availability in Australia was only compatible blood of course, would be Rh, the first option, that there was few number of the frozen Rh units available, but the donor which donated the Rh units could not donate anymore. So the blood services was concerned to save the unit for the donor. Therefore, the call for help was put to the working party, Red ISBT working party, for Rh or any other advices that could help with the patient. International communication started and suggestion came. Dr. France from Dr. Noizet from France actually mentioned a few suggestions that in France, if pregnant woman has a specific risk to bleed, that is like placenta previa, hysterectomy, or history of bleeding, otherwise no reservation of the rare blood is actually taking place. But in case there is a chance of risk of bleeding, then of course it would be appropriate to look for blood. Looking for a donor would be the other option, which was discussed with the other speakers, to donate liquid blood. And if the low hemoglobin level could be treated, or use of erythropoietin drugs could be considered to fix the low level of hemoglobin. Besides, we should consider that 2 units of red cell, in case there is a risk of bleeding, is not sufficient to compensate for low hemoglobin. So additional non-compatible unit should be considered for a transfusion. Since titer of the anti-HRS was only 2, so use of Rh negative, C negative, E negative, and use of for transfusion should be considered. Use of IVIG or corticosteroid drugs to prevent hemolysis would be another option to be used. Testing of MMA, monocyte monolayer assay, could help to decide whether the antibody potency is actually clinically significant or not, and to decide whether we could transfuse incompatible blood for the patient. Also, the baby needs support, transfusion support, that the option of using mother's blood, red blood cell, should be considered. Use of autologous donation during pregnancy would be an option. In this case, unfortunately, the pregnant mom was not able to donate for herself. And of course, using monitoring of the fetus did not show any indication of Hdfn. The IBTO, we have access to 3 donors of D-, which we considered offered to ship to Australia for the patient. That was another consideration for support. And another suggestion was using cell salvage procedure during the pregnancy, and testing the siblings of the patient. American Red Donor Program offered to provide allele matched red blood cell also. Here you see the actually MMA result, which was done by New Zealand. The sample was sent to a member country in New Zealand, and MMA testing was performed, and it showed that reactions of the antibody with different cells had high percentage of incompatibility, and which considered to be clinically significant. Any MMA result less than 3% would be considered not important, but the antibodies showed all showed high percentage of reactivities. Because of the MMA results and high titer of antibodies, the clinical, the physician were still concerned, and they pursued supply of allele matched red cells from United States. But unfortunately, the donors at the time were not available to donate. So the shipment of the Rh were considered to be helpful, and the contact was done, and we were prepared to ship the units to Australia, but luckily patient delivered a baby girl 12 days early without any incident. And the baby blood, as you can see, was O positive, and the phenotype big C negative, little c positive, big E positive, little e positive. Anti-D, anti-E were eluted from cord blood. All panel cells were reacting with the cord plasma, indicating anti-D, E, HR, HRS in cord plasma. And because of, and since we had a happy and uplifting ending to the scenario. This was actually a case that shows that how we could approach to support a patient with the in need of red blood within an international cooperation, and the suggestions that can help to actually meet the difficulties and challenges. And thank you for the time. And I end here. I actually thank AATM and the organizer of the Dr. Poonam and Dr. Rhce and the organizer of the program. Thank you for listening.
Thank you, Dr. Mustafa. That was such an excellent presentation, and we are happy that we could hear your case. And I think the time has come for international cooperation with the types of variations we are detecting with intercaste, international marriages. We are going to see more and more of variations, and this cooperation has to go on, especially with molecular testing, availability of molecular testing. When it becomes more easily available, easily accessible, we are going to see a lot of such difficult cases, and we will have insight how to handle them with cooperation. So with that, I should hand over to my co-chairperson, Dr. Swati, and the other Dr. Rhce and Ankit for comments.
Thank you, Poonam. It was an excellent feast today on the Rh blood group system. And maybe I think questions, I think the coordinators or other people will ask. But for me, I felt that now we know the number of blood group antigens are increasing almost up 60. As exactly told, there are some challenges, mainly to know the correct Rh status, maybe serology complementing with the molecular, it will be helpful on that. Then providing CC matched blood to reduce the incidence of elimination, because I think many of the elimination are due to capital C, small c, capital E, and small e antigen. Then prophylaxis to all Rh negative women. Maybe the new methods for non-invasive fetal Rhd typing can come into picture. And for especially for the management of Rh eliminized pregnancies, then very important, identifying very rare Rh phenotypes like D-, Rh null and all, and putting them in the registry, especially after doing family studies. Most of these Rh phenotypes we identify among patients, but getting a donor especially is something very difficult. So with all these challenges, but with all those bright lectures, I think we have good days ahead and something. So I would like to thank Atom for giving me the opportunity to be a chairperson for such an excellent meeting. And I hope still many problems in the Rh blood group system are in the future. We'll have more challenges because this is one of the most complex and most immunogenic blood group system. I think over to Dr. Ankit.
Yeah, thank you, ma'am. Like if there are any queries, you can post over here or you can raise your hand. I think somewhere there, Soumya had already answered them. And Mujtaba has, he had to go somewhere. So he has posted his email ID also if anybody has a query. So
Anybody
we have...
anyone want to ask any question? Please go ahead, unmute yourself and ask the question. Okay, so nobody has raised the Moham. I don't see anybody answering questioning anything.
there was one question from Dr. Vinu. Okay. How was compatible blood obtained in this case? I think it is to Dr. Anila Mani. I think she had told. If Dr. Anila wants to elaborate.
Okay, sir. For my case, it was very difficult to obtain a cross-match compatible unit, as this is a newborn and we are supposed to transfuse the baby with the blood which is matched with the maternal serum. But here, since the maternal serum was giving incompatibility with all the units which we had to cross-match with the baby's own serum only. And since it was on day 3, the transfusion has taken place. Already whatever antibodies were there, it has already cleared from the circulation of the baby, we guess. And the baby had already received quadruple surface phototherapy and even IVIG. So luckily, post-transfusion, we could get a good post-transfusion hemoglobin value also. So I guess it's clear for weapon. We know.
Okay, we know. And the next question, I think Soumya had already answered. It was regarding plex for mothers with Hdfn, preventing them. Do you want to say anything more, Soumya?
Okay, so I'll be going ahead with the same answer only. So the plex is an option which, in case of heavily allo-immunized mothers, can be attempted till you have an option to do the intrauterine transfusion. So I mean, ASFA also is currently with the guidelines that we can take it up as the strategy in the first and the second trimester till we get a chance to do the intrauterine transfusion. So, and the preferable replacement fluid, which was the next question also. So albumin will be a choice rather than going for fresh frozen plasma. To my practical experience, I have not done. I am just going by the theoretical knowledge, what I have gained. Anybody, any of the experts can add to the same. Swati ma'am or Poonam ma'am, Jan, Mustafa sir.
Even I don't have much experience of exchange, but I emphasize on one thing, that prenatal antenatal antibody detection is a must. And Rh-ND, Rh-D is a big problem in our country. We must work together so that we don't have to face Hdfn. It's a preventable thing. So a correct blood grouping, antenatal or any type, it's very important. At times we see cases where a group is wrongly interpreted, whether sometimes Rh negative is given, Rh positive, because most of the labs which are not blood banks, where the routine grouping is done, is still rely on slide testing, especially in remote areas. And NTD testing on slide is not at all reliable. Sometimes you don't give time, that 1 minute time which has to be given is not given. So we face a lot of problem from the remote areas when these ladies are coming after second or third pregnancy, and when you see the titer has gone so much. Moreover, the immunoprophylaxis, RHIG, is not given timely. That 28 weeks, how many time our Rh negative patients are getting immunization at 28 weeks? That is still questionable. So we need to work simultaneously on these lines also. That is my update. And this had been excellent presentation from everybody, and I gained a lot. I'm so happy, and I'm especially thankful to all the people, Ankit, Rafi, Dr. Chaudhary, just to give me this opportunity to be here. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. I must thank you, all the faculty members. These were excellent talks, very interesting. Rh is a complex system, so we have to understand it more. So we have to share our knowledge, and we have to understand the Rh system, and we will try to solve our cases, whatever complex cases we have. Thank you, Jane, Dr. Mustafa, Soumya, Anila, Dr. Poonam, everybody. So I don't see any more questions coming. We can conclude this meeting, Rafi.
Okay, thank you, sir. Thank you, everyone.
Jane, do you want to say something? Jane?
No, just thank you for an excellent program. Just going to wave bye.
Okay.
Dr. Chaudhary, is it there? Okay. So have a nice day. Good night. Good day.
Good night.
Good night. Thank you.
Good day, Jan.
Yeah. Bye.
Bye.